Welcome to the session. I think we should make a start. I don't think there is a chairman, so it's just me. So I'll introduce myself. My name is Bobby Gaspar. I'm a researcher and doctor at Great Ormond Street Hospital and UCL. So I'm going to talk a little bit about ex vivo gene therapy. So focusing really on ex vivo and bone marrow gene therapy for monogenic rare diseases, and talking about the translational pathway and early clinical trials. So this is really just a very simple slide about talking about where gene therapy is heading in various pediatric rare conditions. And as you'll see from the program of this meeting, the enormous I put this slide up a number of years ago, but you'll see the enormous advances that have been made in trying to look at specific rare diseases and trying to develop gene therapy. And lots of different approaches are being used. So, you've got eye disorders, cystic fibrosis, obviously. There are now gene therapy approaches for skin conditions, inborn errors, targeting the liver, and also hemophilia, muscle gene therapy with direct injection into muscle. But essentially, what I'm going to focus on is ex vivo gene therapy. So the ability to take out tissue, manipulate it, introduce genes into those tissues, and then return it back into patients. And really, the tissue, the organ that where this has been done to the greatest extent is obviously the bone marrow. And so what I will focus on is the developments that have been undertaken for severe immune deficiencies, for lysosomal storage diseases, and then just a word about hemoglobinopathies at the end, because these are the three main areas where this area has progressed. My area of focus is on severe immunodeficiencies, and I'll give you a snapshot of what is happening in these areas, but the more detailed talks will come later on during the meetings, and I'll try and highlight those as we go along, and you'll get more detailed presentations there. What I want to do is to give, as befits this session, an educational overview of what's going on in these areas. So, well, why has bone marrow gene therapy been used so frequently for these conditions? Well, essentially because we've got in the bone marrow these stem cells, which then give rise to all the different cells of the blood. So manipulating these cells obviously allows us to collect correct red blood cells, white cells, and immune cells, and also platelets as well, because by manipulating these cells and introducing genes into these cells, which have self-renewal and differentiation capacity, will allow modification of these other lineages as well. And I think the other really important thing about this is that we have had over the years a lot of experience. Would you mind just closing the door, please? Thank you. It's just after there's a buzz coming through. Okay, that's great. So the other thing I think that's really come through is the fact that over the years, through allogeneic stem cell transplantation, we really have had a lot of experience in taking out bone marrow, manipulating it, and then giving back to patients, although it's in an allogeneic setting. And especially as far as stem cells are concerned, there's been a lot of experience and technology that has been developed using magnetic beads to identify stem cell populations and then purify them before giving them back to patients. And there are clinical grade systems that are available to be able to do that. So that ability to take out cells and manipulate them has been there in the clinical setting for a long period of time, and we've been able to exploit that as far as gene therapy is concerned. So as far as the manipulation of bone marrow stem cells is concerned, that again is something that has been, over the years, the subject of a great deal of research and development as well. So this is just one particular protocol that is being used in current gene therapy trials, but others will be used as well. So using a cocktail of cytokines, and in this case it's a stem cell factor, FLT3, TPO, and IL-3, but there are other cocktails that are being used and also others that are in development in order to try and efficiently allow entry of our vehicle, which contains the gene, into this stem cell population, while at the same time preserving the stem cell population and the multilineage commitment of those stem cells. So again, there's an awful lot of work that has gone into doing that and allows us to be able to correct these cells in this fashion. And of course, this has also been coupled with the development of clinical grade reagents that are able to do this. So both clinical grade reagents and also clinical infrastructure that allows us to be able to do this in a clinically applicable manner and then return those cells back into patients. And so this kind of translational research pathway, these are just some some simple thoughts on how that proceeds in terms of actually making these into genetic medicines or applicable in a much wider setting. So obviously we have a developmental phase where we have a proof of concept, development of vectors, in vitro studies to show that they are able to correct cell lines, and then also a proof of concept, usually in small animal models. And I'll show you some examples of that as we go along. So that would be the early phase of this pathway development. So you see this kind of proof of concept often in murine models. Then a translational phase, which is essentially trying to show that in larger numbers or making a more clinically acceptable vector, in larger animal studies to show that this is also effective, and also, most importantly, that this correction is also safe as well. So this would allow us to get the information and the data that would be required to submit to regulatory authorities before proceeding with clinical trials. So that is a very important phase of development that is obviously often very poorly funded, or there are not good avenues for funding, but it's crucial in order to get the information in order to be able to proceed further. Then there will need to be the production, and by that production I mean both the production of the vector itself to clinical grade, but also the production of the corrected cell product. So actually production of vector and also introducing vector into patient cells all has to be done under very careful regulatory conditions, and that allows us then to proceed with clinical trials. And these are often now, because especially in rare diseases, these are phase 1-2 clinical studies. We really can't, certainly in this field of medicine, where there are very few patients that are accessible for treatment, go through the conventional pharmaceutical pathway of 1, 2, 3, 4 phase 1, 2, 3, 4 clinical studies. These are essentially phase 1-2 clinical studies to show both efficacy and safety. And then this last part is uncharted territory as far as these conditions are concerned, and I'm sure those models are being, and there are a lot of people here that have more knowledge of this than I, but this is obviously in the very early phase as far as these gene therapy studies are concerned. Okay, so that's the kind of path, and what I really want to do is focus on some of these translational studies and also the early clinical trials as well. And I'll say I'll give you an overview of these, but more detail will come in other lectures during this conference. So my area is primary immunodeficiencies, and these are now, a number of these are now being targeted for gene therapy. And a lot of that has come about because we know what the molecular defects are that underlie these conditions. So when we talk about, here's the bone marrow, this is in the thymus, and we have early stem cells that can give rise to neutrophils, but also lymphoid cells, and then what we're looking at here is NK cell development, T cell development through the thymus, and B cells. And there are lots of molecules that control these developments that can then give rise to specific immune deficiencies. And some of them result in abnormalities in development, but others cause abnormalities in the function in peripheral cells. And so why do we need gene therapy for these conditions? And we always have to ask that question before we ever start thinking about developing gene therapy. And the reason for this in these conditions is very simple. The standard treatment is an allogeneic bone marrow transplant, which has very good survival figures if we can find a good donor. But when we can't find a good donor, then our survival rates get worse. And especially when we can't find a fully matched donor, we have to resort to a parent or a mismatched donor, our survival figures are only in the region of 60% also. So there is a strong rationale and a strong need to develop better, safer treatments. And so what does gene therapy offer that an allogeneic procedure can't do? And the most important thing here is the fact that gene therapy avoids graft versus host disease. So this is when allogeneic cells see the donor cells, see the recipient as foreign, and cause this graft versus host disease and can cause problems in the skin and the liver, etc. And so by using autologous cells, manipulated autologous cells, we avoid graft versus host disease altogether. And for some conditions, we can do this with little or very little conditioning. So those are the advantages. And so this is data from, I'm just going to show you some results from our institution at Great Ormond Street. And we started off targeting these three conditions, X-linked SCID, ADA SCID, and X-linked CGD, using this first generation of gamma retroviral vectors. And essentially in SCID-X1, what we saw was that by using autologous cells, no conditioning, we were able to get good recovery of the immune system. So these are T cells in these patients, which are essentially zero when they're not treated. And after taking out bone marrow cells, purifying CD34 positive cells, correcting with the retroviral vector, and then reintroducing back into patients, we get good T cell reconstitution. It's essentially all of those patients. And you're aware of these studies that were done by ourselves and also in Paris as well. But of course, these were associated with leukemic transformation. 4 children in Paris, 1 child in London developed these problems. And a lot of, and then subsequently, same kind of tumors were seen in children who had been treated with these vectors for chronic granulomatous disease and Wiskott-Aldrich syndrome as well. And the important thing was really to understand what the mechanism of that leukemogenesis was. And so a lot of work went into that with a lot of groups around the world. And what was identified was these vectors had a propensity for integrating into active genes, and especially growth-promoting genes. And they integrated in and around the transcription start site of these genes and were able, most importantly, to turn those genes on. So you had non-physiological or aberrant expression of known oncogenes such as LMO2. And that's where a number of these integrations were in these patients. So here are 2 integration events in 2 different leukemias in these children. And the virus is sitting next to LMO2 and is able to turn on LMO2. And that is thought to be the precipitating or the initiating event in the pathogenesis of these leukemias. And so what has happened since then, and this is where I think the translational aspect of this has been so important, is that this information has been taken back into the laboratory to design newer, hopefully safer vectors that can then go back into the clinic. So a lot of work has been done in order to generate this new generation of vectors. So what they've been called are self-inactivating vectors, or SIN vectors. I always think that's a slightly strange name to call something that should be better, but that's the name we're stuck with. So these SIN vectors, and what's happened here is that the long terminal repeats of the gamma retroviral vector have been deleted. And so these long terminal repeats contain powerful enhancer elements. And essentially what happened in these leukemias is when the vector sat next to that oncogene, the enhancer elements were able to turn that oncogene on. And so the new design means that these LTRs are deleted, so that enhancer activity has been removed. And so the gene is now transcribed by an internal promoter. And what we have used are mammalian promoters to drive the transcription of these genes. And these mammalian promoters do not have those powerful enhancer elements. And so the real important point of this is that if this vector should sit next to an oncogene, it doesn't have the ability to turn that oncogene on. Also, by using lentiviral vectors as a backbone, we also get a different integration pattern into the genome. And so this is just an example of the safety associated with these vectors. So in this study, what the investigators did was to, in a T-cell line, they were able to put in an insertion site and introduce vectors into that insertion site that was next to LMO2, and then looked for the turning on of LMO2 by the different vector configurations. And so if you use the traditional vector configurations where there are LTRs that are intact, then you get high upregulation of LMO2. But if you start to use these new SYN design of vectors, then you don't get LMO2 expression, or you substantially reduce LMO2 expression. So this vector was put through this translational process, looking at the safety, which I've shown you, but also at efficacy as well in murine models. And here in the SCID X1 model, murine model, the vector was used in murine transplants. And what we have here are wild type. This is using the old gamma retroviral vector, and then this with the new SYN design vector. And what you can see here is T-cell recovery is equivalent, B-cell recovery is equivalent, and importantly in the thymus as well, thymic recovery is equivalent as well. So in terms of efficacy, this vector seems to perform as well as the previous vector, but in terms of safety, it surpasses. It has a lower oncogenic potential than the previous vector. And so with this kind of information, and I'm just showing you a little snapshot of the safety data that was done, but an awful lot of other data was generated by a number of groups around Europe and also in the US. Then this vector was taken forward to a clinical study. And Adrian Thrasher will present this, I think it's on Sunday, and we'll give you more detail on the study. But essentially, this is a study that's been conducted between Great Ormond Street, Paris, Boston, Cincinnati Children, and Los Angeles as well. And 9 patients have been treated in total. Here, the vector was produced to clinical grade. This is the cocktail of cytokines that is used to transduce autologous patient cells, 3 rounds of transduction in retronectin-coated bags, and then infused into the patient without any chemotherapy preparation. And so this is the recovery of T cells following this kind of procedure, and this is just in 4 patients, but as I say, Adrian will give you more detail on the other patients. But you can see the recovery of the T cell population in these patients. There are comparisons that have been made between this and the previous trial, and although the early kinetics of T cell reconstitution seem to be slower using this vector, possibly because that promoter is not as strong, the eventual numbers of T cells that are reached are actually the same between the 2 studies. So this is obviously very promising. The early integration analysis suggests that there is less integration into known oncogenes or genes that are thought to be harmful in this situation. There's no evidence of clonal dominance at this stage as well. But of course, we need much longer clinical follow-up before we can say that this is truly safe. But certainly the early signs are encouraging, both in terms of efficacy and also safety as well. So the other condition that has been targeted is adenosine deaminase deficiency. And so this is a condition whereby DNA is broken down and then has to be resalvaged, and adenosine has to be converted to inosine, and ADA catalyzes that step. The absence of ADA leads to the buildup of deoxyadenosine and the buildup of deoxy-ATP, which are both compounds are toxic to lymphocyte maturation and proliferation. Gamma retroviral vector studies were performed for this disease, and 42 patients were treated in Milan, London, and at 2 sites in the USA. In these studies, a gamma retroviral vector was used. These patients received a low dose of chemotherapy conditioning before the cells were transplanted. And the important thing here is that it's 100% survival in these patients, and 75%, or near 75% of patients have been able to stop enzyme replacement therapy. So the metabolic and the immune reconstitution is as a result of the gene therapy procedure alone. So this was obviously very encouraging. The only issue really is, again, about the use of this particular vector design, because although no leukemic transformations were seen in ADA deficiency, and the reasons for that are not completely clear, we and others have seen integrations in and around genes that are known to be associated with oncogenesis. And so this is data from our center into MDS and EVI1, and these are integrations that were associated with leukemia in a trial for CGD using a gamma retroviral vector. And you can see here these insertions in intron 1 and intron 2 around MDS EVI1. And we're seeing the same integrations using the vector that we've used for ADA. So there would be concerns that long-term there may be a potential for oncogenesis because this vector is able to turn on MDS EVI1. So for those reasons, and because of the concerns of regulators, we moved to a lentiviral vector with this self-inactivating design. And so what we used was an internal promoter, the short form of the EF1 alpha promoter, driving a codon-optimized version of the ADA gene in this HIV SYN backbone. And again, using the murine model of ADA deficiency, we were able to do murine transplants, which showed that this vector was also able to promote immune reconstitution. And so we have data here in the thymus, and in the spleen as well. These are untreated mice on the left-hand side, and then these are mice that are treated with the gamma retroviral vector, the new lentiviral vector, or wild-type mice, or enzyme-treated mice. And as you can see, there is equivalent recovery of the immune system using this new vector. And again, importantly, we did the safety studies that looks at whether we can actually immortalize cells using high copy number transduction of murine stem cells. And this in vitro immortalization assay, or the IVIM assay, has been used a lot to show the potential safety of these vector designs. And you can see here that using the two vectors here that have the LTRs, the old LTR designs, you see clonal outgrowth, but you can't induce any kind of clonal outgrowth with this construct. So it's just, again, illustrating that this has greater safety potential. And so this kind of data was generated both by ourselves and Don Cohn's lab in Los Angeles and taken forward to a clinical study. And so these two centers are undertaking this phase 1/2 clinical study. And again, I'll just show you some early data on this. And these are the first 4 patients that we've treated. And they all start off with low lymphocyte counts, but are starting to recover lymphocyte counts. And probably most importantly, these are the first 4 patients. These are their T-cell numbers. And this is really what we want to see corrected. And you can see that they all start off with low numbers of T cells and CD4 cells. And over time, those have started to increase in all these patients. And this is now without any enzyme replacement therapy. And so even in the latest patient, who's only 4 months after treatment, we're starting to see the recovery of those cells. So again, this vector is showing encouraging efficacy in the early clinical phase, clinical trial setting. We're also seeing metabolic recovery as well. So this is just the levels of deoxy-ATP, one of those metabolic toxic substrates, which are low when you're on enzyme replacement, but remain low. There's a slight increase here, but that increase is not really significant after gene therapy. But importantly here, this is showing intracellular ADA activity, which is low when you're on enzyme replacement, but you now have intracellular ADA activity in red blood cells that is in the normal range post-treatment, which allows detoxification of the system. We're also looking at integration site analysis, and this is again quite interesting, because what we're seeing actually is not a truly polyclonal repertoire within these cells, but what we see is clonal fluctuation. So we see some clones emerging and then going down again. And this may be what you might expect to see in an empty system that is going through repopulation, but we haven't seen any persistence of clones. And we need to obviously follow this up over time and see what happens. We've only got data out to 12 months at the moment, but we'll follow these children very carefully. If we look at the T-cell repertoire, even though there is a large expansion here, over 50% of T-cells containing this particular expansion, the T-cell repertoire is polyclonal in itself. So it may just be an issue of marking within that population. So that is for ADA deficiency. So we have that trial for ADA deficiency. There's also a trial now for Wiskott-Aldrich syndrome using a lentiviral backbone, using the endogenous Wiskott-Aldrich syndrome promoter to drive transcription of the gene. And this is, again, using conditioning now. We start to use, now as we get into these diseases, we start to use much higher doses of conditioning that is akin to what we would use in an allogeneic procedure. And early data from this is also encouraging. You'll have heard or you'll see presented data from the Milan group, which has recently been published in Science, which shows effective recovery of the immune system, correction of the eczema that these patients have, and also correction of the thrombocytopenia as well. So all of this seems to be improved by the gene therapy procedure without, again, any adverse events. These are two patients that were treated at our institution who started to show increasing naive T cells, restoration of T cell responses. They've now, their eczema and autoimmune symptoms have also receded as well following the gene therapy procedure. And in the data that we have so far is that in this Wiskott study, we see a very polyclonal pattern of integration up to 2 years after the gene therapy procedure. And similarly, a trial is opened for lentiviral gene therapy for chronic granulomatous disease as well. This is a neutrophil defect, so it's not about development of neutrophil, but it's about the function of neutrophils that are in the periphery, and they are unable to produce the NADPH oxidase that is required for bacterial killing. So a trial using gamma retroviral vectors showed some efficacy, but was complicated by leukemias in those patients. And now using this trial, we hope that we'll see similar efficacy, but obviously with greater safety. And in this particular vector, we have a myeloid-specific promoter that is driving the expression of the transgene in order to try and maximize expression of the transgene in the neutrophil lineage. So just the first patient has been treated at Great Ormond Street, but the trial is hopefully opening in Paris and in Zurich and Frankfurt as well. So these are the trials, as I say, that are open now at our institution, and these are the 4 immunodeficiency trials that are essentially open worldwide: SCID-X1, ADA SCID, Wiskott-Aldrich syndrome, and chronic granulomatous disease as well. But if we look at this, go back to this schema here, what I'm highlighting here are the other conditions which are likely to have a gene therapy option available fairly soon as a result of the preclinical work that is being done and proof of concept in animal models. So for SCID forms, at the moment, as I say, we have ADA and gamma chain, but it's very likely that we'll also have gene therapy options in the next few years for the recombinase activating gene, which is the RAG genes, RAG1 and 2, and also the Artemis forms of SCID as well. So probably 80% of all the different forms of SCID, genetic forms of SCID, will have some form of gene therapy application in the next few years. And then there are phagocytic defects, so chronic granulomatous disease, and also leukocyte adhesion deficiency. Trials for that will open, and also for disorders of T cell and NK cell regulation, which give rise to HLH. There's proof of concept now for XLP and also for perforin deficiency as well. So these murine models have been shown to correct the disease, and those are being worked up for clinical trials. So I'm going to move now really to talk about more widespread conditions. And so these are metabolic diseases, and especially lysosomal storage diseases. And the important thing here is, of course, that we're not targeting just one system. We're looking at a correction of abnormalities in multiple systems. So in these conditions, these affect the bone and cartilage, the hematopoietic system, in muscle, liver and spleen, abnormalities, heart and lung in some conditions, and most importantly, of course, the brain as well. And the principle behind correction of these diseases is really to try and express the enzyme, the defect, and often these are, in the lysosomal storage disease at least, these are enzymes, to express them at very high levels. And what we want also are, by correcting the bone marrow, is to be able to correct precursors that will be able to cross the blood-brain barrier and also allow delivery of the transgene at high levels to the brain in order to try and prevent neurological deterioration. So this is really quite a big challenge. Transplants in these conditions don't always work effectively. So for certain conditions, transplant works reasonably well, but for other conditions, transplant really doesn't have a great effect, probably because the white cells of the bone marrow do not express those enzymes at particularly high levels. So you just can't get enough enzyme expressed by doing an allogeneic procedure. But what you can do is, if you target bone marrow stem cells and you express either through an appropriate promoter or through high copy number, you can drive high level expression of the enzyme through gene therapy. So gene therapy may have an advantage over transplant through that route. And so the first demonstration of this was not in a lysosomal storage disease, but in a paroxysmal disease called Adrenoleuca dystrophy, and this is work that was done by Patrick Oberg and by Nathalie Cartier, and in X-linked Adrenoleuca dystrophy. And what they were able to do was taking bone marrow cells, transducing them to high copy, allowing expression of the enzyme. They were able to show stable correction of peripheral cells over now 4 years after the treatment. But importantly, and what was reported in this Science publication, was that they were able to prevent neurological deterioration. That is shown here. This is an untreated individual, so this is just by comparison at diagnosis, and then if left untreated, you can see on these MRI scans this significant high signal activity showing demyelination in this individual. And here are two individuals who were treated and are reported here, who have started to show MRI neurological changes, but is essentially static at significant time points after the procedure, and are significantly different from what was seen in an untreated individual. So that was extremely promising, and a larger study is now being undertaken by Bluebird Bio in multiple centers. And so if we look at the lysosomal storage disease, there are a number of lysosomal storage diseases, some of which have enzyme replacement therapy, some of which are amenable for transplant, and a number of which are now being targeted by gene therapy. And that's difficult to read. But the most impressive and most recent data, which again you'll hear later on, is in chromatic leukodystrophy, which is a very, very debilitating disease, which is a significant neurological deterioration, and which has been the subject of this study from the Milan group with Alessandro Biffi and Luigi Naldini. And really, these are extraordinary results that have come through from this group. And if you look at the paper and you look at the videos of these children after treatment in these children, it's really quite remarkable. But again, you're seeing the same thing. So in an untreated individual, you start to see significant deterioration, whereas in these individuals, there is no deterioration after the gene therapy. And this really comes down to being able to transduce bone marrow cells at high copy number, and allowing high levels of enzyme to be expressed, both in the periphery and also by correcting the macrophage lineage, or the macrophage lineage through and crossing the blood-brain barrier into the brain, and allowing neurological preservation as well. So that was shown initially in the mouse model before these, as I say, extremely good results in patients. And a similar approach has been used for targeting MPS I as well, which is the most common form of lysosomal storage disease. And this is the Murine paper, which again follows a similar principle. lentiviral vectors into bone marrow cells, which are then expressing IDUA, which is the lysosomal enzyme that is missing in this disease, in order to correct multiple system abnormalities. So here there was correction of bone, of heart, muscle, of storage tissue in the liver and in the spleen, and also neurological correction in these murine systems. And this data is now being taken forward for a clinical trial, which will open in Milan, I think, next year. Here's another example. This is a different condition, doesn't have such a strong brain effect, but this is Pompe disease, which is actually a glycogen storage disease. But this enzyme, the lack of this enzyme leads to muscle abnormalities. So there is heart failure, there is respiratory failure, there is peripheral muscle failure. And here, using, again, a lentiviral vector, they were able to show correction of these problems. One of the things that you can see here is these are wild-type mice, these are untreated mice, and these are gene therapy treated mice. And so you can see that there's only partial correction, or 50% correction to normal levels. And this was using a vector with an internal viral promoter. So it's the SFFE promoter, but as an internal promoter. And here you're not getting full correction. So again, suggests that you're not delivering enough enzyme. So the challenge here is to actually improve that expression cassette to be able to express at much higher levels in order to get full correction of the disease before then going on to clinical studies. And so finally, I'm just going to show you this, the work that is now taking place. And this was the first study of transfusion independence following lentiviral gene therapy for beta thalassemia, and other trials are now starting to take place. In this initial study, a lot of the correction was coming from clonal expansion, which wasn't malignant, but was a clonal dominance, which was producing a significant amount of the hemoglobin in this patient. And this individual has remained transfusion independent. But obviously, there's an awful lot further to go to show that this is effective in a larger number of patients. So I think I'll just leave you with just the last few slides. Basically, again, the proof of principle, as I say, does need to be in these animal models before doing these translational studies of both large-scale efficacy and safety, before going into these early phase studies, which are phase 1 and 2. And I say we will not get past in rare diseases these phase 1, 2 studies before we then want to try and market them or try and license them as genetic medicines. And so just a final point. So now we can say that there are cures for specific immune deficiencies and metabolic conditions. And these are the first ever cures with gene therapy. And even though these are intensive interventional studies, the morbidity and mortality is still low in comparison to other treatments, which we now see as standard of care, for example, organ transplants and allogeneic transplantation. We clearly need newer, safer vectors, and we need to think about each disease individually in terms of gene regulation, the level expression, and the tissue specificity. And with that, I'll stop there. Thank you very much. So I'm very happy to take some questions. I think we've got some time.
Thank you, Bobby. I had a question about the, you mentioned a couple of instances where there was translational data in animal models, specifically murine.
Yeah.
Can you comment on how we need to think about whether it's okay to do murine versus non-human primates, and kind of how to think about it?
Yeah, so it's difficult. If you're looking at disease models, as opposed to we don't have primate disease models. We have normal primates when we can look to see what the safety of those vectors is, and you can only do it to a small scale. If we want to show efficacy, we can really only do it in a disease model, and for the most part, those are murine models. There are, for some diseases, for example, for leukocyte adhesion deficiency, there is a dog model that is available, and for certain other conditions, there may be dog or larger animal models. So if that is available, then obviously that is an avenue to go down. But in the first instance, it is quicker to get the proof of efficacy or the proof of concept in a murine model. And if necessary, and if available, then a larger animal disease model to show proof of concept. A lot of these studies have gone forward to clinical application without going through the primate route. And again, that's very difficult.
Absolutely. Thanks.
I was wondering if you can elaborate on why the leukemic complications are so highly correlated to a handful of oncogenes.
Why they're related to, well,
why correlated to a handful? Because
Okay.
there are hundreds of them, and insertion sites are occurring.
yeah. So,
Yeah.
so in, for example, X-linked SCID, the driver there is the fact that it's a T-cell disease. And so when the stem cells are transduced, it is likely that there are integrations, as you say, into a number of different oncogenes. But the population, the lineage that is being driven, as it were, by these oncogenes is in the T-cell lineage. And so LMO2 is known to be a risk factor for T-cell ALL. And so probably clones that have LMO2 integrations are the ones that are starting to proliferate and the ones that then undergo through replicative stress or increased turnover, then start to accumulate other mutations, which then go on to form a leukemia. And similarly, in chronic granulomatous disease, which is a neutrophil disorder, then it was in MDS and EVI1, which then led to an AML, an acute myeloid leukemia. So it may be related, say, to the underlying disease pathogenesis and how that's being driven.
So it's purely context dependent, honestly.
Yeah, I think it is context dependent, yes.
Yeah, but the other oncogenes are presumably also.
Other oncogenes are also targeted, but they're not necessarily being driven in terms of that disease context.
Thanks.
Any other questions? As I say, there's a lot of, there are going to be a number of talks about these specific diseases during the course of the meeting, and you'll get more detail on those in those sessions. Okay. If there are no more questions, then thank you very much. And now the next speaker is here.